a city of promise and home to Asia's largest slum, and as of the 4th of April this year, reporting 11,000 COVID-19 cases every day. On the 11th of May, that daily count had dropped to 1,717. The pullback in COVID-19 cases during the second wave is not a mere coincidence, but a combination of foresight, leadership, and political backing. A model that has been hailed by the Supreme Court and emulated in other cities too. So what exactly is the Mumbai model? First, let's talk about the architect of the model, Iqbal Singh Chahal, a 1989 batch IAS officer who took over the BMC or the Municipal Corporation in May 2020 when the worst of the pandemic was beginning to unfold for the first time. Controlling cases in Dharavi, which is Asia's largest slum, was his challenge in the first wave. This time around, it was dealing with the tsunami of cases in the second wave. So here's how he and his team did it. The city created jumbo facilities to treat COVID-19 patients where large open spaces were set up as free healthcare centers. The city has 6 such centers and plans to add 3 more. Many of these centers are air-conditioned and have ICU beds, oxygen beds and ventilators. Triaging is when authorities determine the order in which patients are treated. Under this system, the BMC receives all COVID-positive reports directly from testing labs and reaches out to patients through war rooms to determine which ones need hospitalization. This ensures that hospital beds are utilized by the most needy patients and not overwhelmed. The process received a lot of pushback as well, with some Mumbaikars not happy to be directed to government centers instead of private hospitals.
We would be visiting them home to home and offering them bed at their residence. And then the same ambulances which go from a war room, they drop patients on the hospital beds.
A key component of the Mumbai model is a decentralized system with a war room for each of the 24 wards in Mumbai that are manned by 3 shifts working 24/7. 720 doctors in the war room are in charge of reaching out to and identifying the needs of patients. The war rooms were staffed from medical colleges as well, with a stipend of 50,000 rupees per month. A successful model also requires efficient implementation and an ability to respond to situations quickly. On the 16th of April, Mumbai averted a catastrophe when 6 hospitals with 168 patients ran out of oxygen and had to be rushed to jumbo centers via 150 ambulances. The next day, Chahal reached out to the center and requested for oxygen to be diverted from the Jamnagar facility of Reliance Industries. The use of technology, from Uber's software for tracking BMC ambulances to IIT aid in tracking space in crematoriums to the successful use of social media to communicate with citizens, has truly made the Mumbai model one that needs to be followed and implemented across the country. Bureau Report, ET Now.
And to speak now on the Mumbai model and whether it is possible to take some learnings from it to control at least infections and deaths in other parts of the country, I'm joined today by Dr. Shashank Joshi. He's a member of the Maharashtra COVID Task Force, and Dr. Giridhar Babu, who's the head of Lifecourse Epidemiology at PHFI. Welcome to both of you, and thank you so much for speaking with us. Dr. Joshi, let me just begin by asking whether the Mumbai model is something that can be emulated in other parts of the country. It's being talked about, and as we've seen in the report, because of the ability to identify the patients who need to be hospitalized and a more decentralized approach instead of just one control room. Is it possible to do that in other cities which may not have so many resources as Mumbai, as the financial center, does?
Tamanna, absolutely. I think Mumbai model is just not linked to the financial or resource backup, but also it is linked to the capability and ability of people to upscale it. So there are 3-4 parts of this Mumbai model. Last year in the first wave, we had changed the virus policy. The predominant wave was in the slums like Dharavi, and that was the model then. This year, the wave was predominantly in the middle class and the neo-rich class. The one thing which worked was decentralization, having 24 Mumbais, 24 war rooms, and having an assessment, transparent triage and managing strategy all at once, following a 21-day timetable, staying connected with the patient and chasing the patient, which can all be done in any geography of India or any part of the world, provided the challenge was there. But the peak time, very high numbers, the bailout was possibly because we had between the private hospitals, which all doubled up their capacity, which was a problem, and the public health system, was the jumbo facilities. And I think that gave the cushion, which was badly needed. That part may not be always doable in other geographies. The other thing is that triaging helped us to identify two things. A lot of asymptomatic and mildly symptomatic patients were occupying hospital beds. And if we were able to construct the corona care centers, which were able to manage these patients, and we also added 5-star hotels at this point of time, if they were digitally connected with their doctors for asymptomatic cases, then we were able to get that extra cushion. The other thing which is very doable in all districts across the country is to have an open dashboard which is updated every hour, so that people have transparently a vision of the number of beds available in different parts and different hospitals, nursing homes, private and public both, the number of beds which need oxygen, number of beds which need ventilator, care beds, ICU beds. It actually creates a transparent system where people don't have to run from pillar to post, and it eases out the panic and gives a lot of confidence building. So many of these digital versions and the hub and spoke model, the decentralized approach, is very doable and very, very manageable. And also, I think most of the corporations as well as smaller places have infrastructures to have innovative ways of doing these corona care centers in their local geography. So obviously, this is an adaptable model, and our primary focus is to save every life. We are still not out of the woods. We are definitely better than the curve, but we are still not out of the woods. We still maintain our standard public health emergency strategies of testing, isolating, treating. At the same time, we also try to maintain that the model is still intact, and we keep on building up capacities for any future eventuality. Because remember, this model operated, and we also went into a period of restrictions. And we will have to sort of ease out restrictions in the coming couple of weeks. So we need to be very mindful of that fact.
That is the big question. How do you balance keeping this kind of a model in place when you eventually have to ease out restrictions? Dr. Babu, can you give us a perspective with the example of Karnataka? Bengaluru has been widely reported to be looking at some elements of the Mumbai model. What has been adopted and how can this help?
Yeah, I agree with Dr. Shashank. So in terms of the salient features of Mumbai model can be replicated in most places. Which includes better triage, ensuring that there is an efficient exit mechanism from the hospitals, which means that those who are getting well are discharged in time, and also people with mild illness are not occupying those beds. What is probably missing, as he clearly stated, is the jumbo ICU facilities is one, but more importantly, the leadership. I know they are playing it very humble, including Dr. Shashank Joshi and other task force members, but they might take the pride in great leadership, both at the state level and also at the Mumbai city level. And now that at least people are getting to watch some of the important features, Mr. Chahal, the way he has led Mumbai from the front and by making sure that everybody is working as a team, is most important. There are three aspects of the leadership which are very key here. One, because of strong leadership, they have been able to allow that everybody gets in line and nobody jumps the queue in terms of admission. So that requires tremendous amount of leadership. Second, doctors and other healthcare workers have been paid well and they've been made to stay in better facilities and take care of the triage, at least through the tele-triage system. And most importantly, people are working in the field instead of working remotely. They go, they make sure that all the things are done in the field by facilitating supportive supervision. These three elements are replicable, but then it all depends on how easily we can adopt this system. What I see is missing currently, Tamanna, is the approach for learning. We need to be looking at the salient success features of each model, whether it is Mumbai model, Kerala model, and each state has its own strength. Even within Karnataka, there will be few strong points which can be replicated elsewhere. Instead of doing collaborative learning, I often find that when Mumbai is surging, everybody will say it's Mumbai's fault. When Delhi is surging, people say it is Delhi's fault. And now it is Bangalore's fault that Bangalore is surging. And this does not promote learning. So we should be ready for learning. Then only we can incorporate these lessons.
Yeah, that's a very good point, Dr. Babu, because it does become about finger pointing and who has managed, who has mismanaged, but we will also have to agree that the difference in the way different parts of the country are responding to COVID-19 is reflecting in the number of cases and the number of deaths. So that has to be looked at, keeping ego aside. Now let me come to the question and follow up for Dr. Babu here. How can you utilize this in rural parts of the country? Today as well, the Prime Minister has said that COVID-19 is now showing its presence in rural India. There are many reports that it's going through rural India, and sometimes in a scary fashion where there's no testing, there's no acknowledgement that it's COVID. It's difficult sometimes to even know how many deaths there really are. So what lessons can be taken from here, and does the administrative capability exist to use some of these methods in larger parts of the country away from the cities?
Yeah, so Mumbai has a luxury, I would say, in terms of having the required public health manpower, required resources, and tremendous levels of leadership in getting the things done. Unfortunately, in most rural areas, this is not the case. I have worked in Uttar Pradesh and Bihar for more than a year and a half in polio eradication program. Things have not changed much, even in terms of testing. Let's start from testing where both the people who are having the stigma to get tested and the facilities available for testing and the approach and the culture of encouraging testing and reporting cases does not simply exist in most of the hard-hit areas. And therefore, once you detect cases at a very lower rate, you're actually denying the opportunity for better care. And better care is only a mirage. It's only a dream in most of these places. So we need different approaches. And some of the salient features of Mumbai model which can help in rural areas are tele-triaging. And added to that will be tele-ICU, which has been piloted in Bangalore and rest of the Karnataka. And using these resources, which are the ways in which we can identify people who require hospitalization, how fast can we refer them, and again, these things can be taken from Mumbai model. So the deficiency in human resources cannot be actually filled by temporary manpower. If we don't hire them now, when would we? And if you look at the kind of hiring done by the state governments or the central government, we are still looking at a huge crisis in terms of manpower. I'm sorry, that's not the right word. It's mostly the women who are the frontline workers. And it's the ASHAs and the ANMs which are not filled. And in urban areas, we simply do not have the number of people required for contact tracing testing. Therefore, you are always mobilizing people from other sectors who are voluntary in nature and temporary in nature. So I think we need to take a different approach in rest of the areas. For rural areas, we need to see how to strengthen referral and early treatment in tertiary facilities. For urban areas, we need to include and strengthen the primary healthcare services by having more frontline workers.
I want to take that same question to Dr. Joshi. And Dr. Joshi, forget about rural areas in other parts of the country. We know that the difficulty and the challenge of implementing Mumbai's own model, even in other parts of Maharashtra or in rural parts of Maharashtra. So is that where the big challenge lies, as now cases may move into, rural India and outside the cities?
Absolutely, Tamanna. I think 2-3 things we need to get. I agree with Dr. Babu. Very clearly, what he highlighted is that even today, there is a lot of stigma. If somebody is symptomatic, whether it is urban or rural, they don't want to go and get tested out there. And a delay occurs. Second is that a simple fact that a COVID timetable is 14 to 21 days. And again, they are not very keen to get trapped into that. Most people think they are asymptomatic. Even if they test, even if the slightest hint, they are not ready to self-isolate. And this time what we have seen is it's a cluster spreading. So the whole family gets affected. And when the whole cluster is affected, obviously then, we have some fatalities. So I think, when it coming down to application of these models, we need to sensitize the community and the frontline and healthcare workers in a proactive way rather than a reactive way. And if we are able to sensitize both these simultaneously in the local languages, using the infrastructure in an optimal way, we can still replicate many parts of the model which are existing. We need to be adaptable, we need to be flexible, but we need to have common goals. One is not to drop the testing numbers at all. At the first instance, test, and all the contacts of the suspects are also traced and tested appropriately. Number 2, not to let our guard down on the RT-PCR testing, because that has to be done. There is no leeway from that. Our dependence on rapid antigen tests in some parts of rural geographies have been one of our drawbacks. And if we do rapid antigen tests and if they are negative, keep a close vigilance with self-isolation for 3 to 5 days so that we can mitigate that challenge. So, we have to do a lot of micromanagement and ensure that we sensitize people at large who necessarily will be healthcare workers but not doctors, and ensure that there is a availability. If the person or the case deteriorates, we have availability of beds, of oxygen, of ventilators there. So I think if that is there and these confidence building measures are done, we can go a long way. But one more thing in what we find as a big barrier in break the chain is that people, despite of so much of deep spread of COVID across the country, inability to mask is something which is very painful and shameful. And I think we still need to be very clear that this is an airborne virus. We need to not go in crowds. We need to have appropriate ventilation. We need to mask or double mask. Still is a big, big problem. And I am telling you that's something which we need to ensure that we do it. Also, we need to keep our focus on testing in the smaller places. So, every model has their pros and cons, and appropriate treatment, early diagnosis, prompt treatment will save the nick of the day. The other thing is in home isolation. Many small geographies are not able to do appropriate home isolation. And that's why many parts in Maharashtra, we had to adapt institutional quarantine models and then filter out cases which desaturate into tertiary care referral centers. Because sometimes in a smaller geography, it is difficult to manage people at home or have an access. And that is where what Dr. Babu was saying is that in Maharashtra, we already have piloted the ICU model, the hub and spoke model, beyond just the telehealth model. And sometimes the institutional quarantine also allows a healthcare worker to take care of the patient and then red flag if there is a deterioration of the case so that we can save every life. Our current focus is very simple as far as Maharashtra and Mumbai is concerned, save every life, because that's our first target. And then we have to break the chain by ensuring that the invisible, asymptomatic, pre-symptomatic, or the suspect cases are contained, because now the overall case load and the case pool is coming down. But we don't want it to rebut again and spring back again as we start easing out our restrictions.
So, that's what I was coming to next, Dr. Joshi, and if I may come back to you with a question on this. And one of the reasons why the Mumbai model also holds out hope, and of course the biggest one being if there are lesser fresh infections every day, the lesser mortality you will see, and we will have less loss of life. But it also points to a possibility that you can go from high infection rates, control them, and hopefully ease out restrictions at some point. Right now, most of the country is in some form of lockdown or the other, and they're getting more and more stringent in other places. Maharashtra was one of the earlier ones to start in the middle of March, and now we're extending till the end of May, till the 1st of June actually. Do you see a place where we can start easing out restrictions as well as the numbers come down and still be able to hold on to this Mumbai model?
So I think we have to do two things in this. First thing is that, as the standard public health strategy is that if the test positivity rate is above 10%, we need to first get it down to below 5%, increase the doubling time, and ensure that the case fatality rate comes down. What happens is, as the test positivity rate comes down, we see over 2 to 3 weeks the case fatality rate going up a little bit. Our current worry is that the case fatality rate is a little peaked up in Maharashtra and Mumbai both, and that's a cause of concern for us. Second thing is that once the test positivity rate comes down below 5% or 2.5%, we actually need to saturate the population with vaccination and masking both. So I think adherence and a behavioral change as well as vaccination both have to go simultaneously, particularly in the vulnerable group. And that's something which we recognize better. But what is happening is that we know that there is a little crisis in terms of vaccine availability is concerned. And we need to cover up as large geographies as possible, and we need to do targeted vaccinations. So this is where the challenges are. But I still feel that we can ease out restrictions in a very, very careful and a mindful way, with zero tolerance for lack of adherence to COVID-appropriate protocols, where we might have some stringent fining measures, which will be difficult for people, which may be punitive at times, till the vaccination is in place to saturate that geography. And the saturation of vaccinations will occur, but it may take 3 to 6 months. We are reasonably certain that this current crisis is a transient one of the vaccination non-availability or poor availability. But I certainly feel that come July, August and September, we will see a large population being vaccinated. And that will definitely make this whole geography a little more sensitive for a mindful unlock. But remember that this year is going to be a masked year, and we will have to mask as we ease out. And there is no tolerance for crowding or poorly ventilated environments. And we cannot just go away from COVID-appropriate behavior if we need to bail us out in an uneased environment. So that's something which we need to be mindful of. And I hope that people have now woken up after the first wave and the second wave, that there is absolutely a possibility of a genuine third wave which is likely to come. Maybe in Maharashtra it may come somewhere in September, maybe in the full country, maybe in November and December. Of course, and that's what the modelers are telling us. But that's something which we need to be very, very careful and mindful of. Also, the other challenge is those people who had exposure to the virus last year. They had probably, their antibody levels will come down. And if we don't saturate them with vaccines, we will again see a surge of infections in that population. So I think that's something which we need to be mindful of. So we just cannot be easy this year. We'll have to be very cautious, very careful, and that's the way to go.
So, talking about vaccinations and the strategy there, Dr. Babu, just, your view on the fact that the time between both doses for Covishield has been increased this week, now from the earlier 6 to 8 weeks to 12 to 16 weeks. Now, this has led to two sets of questions. One is that, are we doing this because there are fewer vaccines, so you want to cover people more? Plus, you're saying if someone's had COVID-19, they should not get vaccinated for 6 months, when the CDC puts that duration down to 4 to 6 weeks. And if 12 to 16 weeks is desirable, then what about those who got the second jab earlier? Are they then at risk?
Yeah, so great question. I wish I had convincing answers for this, because from the beginning, at least some of us have been saying it is better to delay the interval between these two doses, depending on, this was purely based on evidence, and this was not our opinion as such. And the evidence was definitely 8 to 12 weeks is a very good interval. And also a subgroup had better efficacy in even beyond 12 weeks. That was the first set of evidence which came in the Lancet. But at that time, the decision was taken to do at exactly much earlier interval. And the reasoning is also important. They said, when people are unable to turn up at 4 weeks, how can we ensure them that they'll remember it and come back later? So this is one of the remarks I heard from people who are involved in decision making, which means that they had practical reasons why they had to put at the lower limit of what is acceptable. So to answer your question, better is the longer interval, which is 12 weeks and beyond. There's no doubt about that. There is clear evidence which says that anything beyond 8 to 12 weeks is good in terms of efficacy. And in terms of any adverse effects for those who have taken earlier, nobody has taken before 4 weeks. So anything above 4 weeks is safe. So I don't see there's any problem there also.
No, so, but the question also is, and let me get Dr. Joshi's view also on this, that if you're taking it to 16 weeks, are you taking it a little too far, where then the efficacy of the first jab is not as useful? Is that a concern at all?
Tamanna, there is data on Covishield. Covishield is a predictably unpredictable vaccine. And it's all based on one science which has been generated. And, if you do the meta-analysis of 4 trials, 76% efficacy with 1 dose. And then, you stretch it out to that 12 weeks, that is reasonable. I would say 12 weeks is reasonable. 16 weeks, that data is speculative or may not be in public domain. So I'm not privy to the data which the committee is. But there is a logic which Dr. Giridhar R Babu is saying, and I'm also told, that delaying the second dose has some logic for a better efficacy. You see 1 month, 2 months and 3 months. The 3 months, whatever is the public domain data which is published of Covishield shows that it has the best immunogenicity. Beyond 12 weeks, I can't comment because data is not in public domain. So I can't comment on the 16-week part of it. But one thing is there, that when we are in a crisis and we are in a public health emergency, UK did the same thing at the peak of their second surge. And I think they deferred it for 3 months. I think it is very prudent on the part of Government of India to defer it so that we are trying to save and protect a larger population. So I think the intent is reasonable, both in terms of science and in terms of the current situation of a shortage. So I think they have tried to mix and match both, and which seems reasonable. If you ask me, that's a very logical thing. The second part which you asked is that the natural infection usually confers B and T cell immunity for around 3 months. At best, and sometimes up to 6 months. So even that logic appears to be logical in the current circumstance. The idea is that in 3 months, we'll have a sufficient supply chain which will ensure that a larger populace will be vaccinated. I think this is a transient measure because of the current adversity at the peak of second surge, that they have taken a decision so that in this current time, in these 2 to 4 weeks, we are able to cover a larger population. And I think that is something which has been done with a lot of thinking behind it, a lot of science behind it. But the science was available in February. So obviously there are critics who are trying to say, why was it not done earlier? Why is it being done now? I think better late than never. Let's accept the science. Let's accept the prudence. Let's accept that there was a little shortage. And let's accept that probably nobody anticipated the ferocity of the second wave to be so overwhelming on overall the healthcare infrastructure. So I think there has been some degree of acceptance and some degree of course correction, which is reasonable and fair.
Okay, so the bottom line is, if you took your second dose of Covishield after 4 weeks, it's okay. If you now will take it up to 12 weeks to 16 weeks, that's also okay. As long as you take your second dose and stay masked, completely keep all of your COVID-19 protocols, that should be fine, and that's something that you can't get away with. Thank you so much, Dr. Joshi and Dr. Babu, for joining us today and explaining to us how some of the learnings from Mumbai can be used in other parts of the country as well.